Good morning. Welcome to Palliative Care and Geriatrics Grand Rounds. I am Biara Dobman. I'm the course director. I elbowed Kathleen out of the way today because Joanna is my mentee and I really wanted to be able to introduce her because I'm a proud mama. So here goes. Dr. Joanna Sharpless received her bachelor's degree in English literature from Brown University, where she went on to complete medical school in 2015 as part of Brown's program in liberal medical education. She spent a fellowship year during medical school working as a medical researcher and writer for the Dr. Oz show in New York City. She later completed her residency in family and social medicine at Montefiore Medical Center in Bronx, New York, before joining the Harvard Interprofessional Palliative Care Fellowship here as a physician fellow in 2018. She's interested in disparities in end-of-life care for underserved populations and in the use of narrative medicine to promote both professional development for healthcare providers and healing for patients and families facing advanced illness. Please join me in welcoming Dr. Sharpless.
Good morning, everyone. My name is Joanna Sharpless, and I am a palliative care fellow in the Harvard Interprofessional Palliative Care Fellowship Program here at MGH and across town at Dana-Farber. I'm thrilled to be here with you today to present Can We Still Have a Child After You're Gone? Navigating the Challenges of Reproductive Planning with Terminally Ill Patients. This topic first came to my attention when I helped to take care of a young man with terminal cancer in Vicki Jackson's outpatient palliative care clinic this past fall. My background is in family medicine, and up until this year, I had only ever provided reproductive counseling to young people who were healthy. It wasn't until I encountered this young man and his wife that I realized that for people facing a terminal diagnosis, discussions about fertility and reproduction can essentially become end-of-life discussions. I learned a lot from taking care of this couple and from subsequently researching and presenting on this topic at AHPM last month. And I'm looking forward to sharing what I've learned with you today. I have no disclosures. I have 4 objectives for us today. The first is to summarize the evidence and recommendations for fertility counseling for seriously ill patients. The second is to identify the psychosocial and logistical challenges complicating reproductive planning for patients facing a terminal cancer diagnosis. The third is to be able to utilize interdisciplinary methods for alleviating distress caused by reproductive planning in the setting of terminal cancer. And the fourth is to explore the ethical complexities of reproductive planning for terminally ill patients. I want to add that while I've narrowed the scope of my presentation today to focus mainly on patients with cancer, much of what I'll talk about today also applies to patients and families facing other life-limiting illnesses. I want to start by telling you a little bit more about the patient who I mentioned earlier. He was a 33-year-old married man who was unfortunately diagnosed with metastatic non-small cell lung cancer in the same summer that he and his wife had originally planned to try to conceive a child. He did complete sperm banking prior to initiation of his cancer treatment, but unfortunately his disease progressed very rapidly and it became clear that he was not going to survive. Throughout this period, he experienced such severe death anxiety that he was unwilling or unable to tolerate conversations about the details of his disease progression and his poor prognosis. He was also not willing to engage in any hypothetical conversations about a future in which he might no longer exist. His wife was of a similar age and throughout this period experienced severe anticipatory grief, not just about the impending loss of her husband, but also about the idea that she might lose her chance to become a parent. She had a very strong desire to be a mother and was very vocal about her fears and concerns with the palliative care and oncology staff. And one day I ran into her on the cul-de-sac outside of MGH and she was crying and she turned to me and said, "I guess I'll never be a mother now," which was really heartbreaking and I didn't know at all how to respond. Complicating things further for her, one of the staff members helping to take care of her husband was pregnant at the time, and she confessed that seeing that reminded her of what she was losing. In addition to his severe death anxiety, and her anticipatory grief, they faced other barriers to reproductive planning. As if this weren't enough, the patient's mother was vehemently opposed to her daughter-in-law using his sperm to have his child after his death, and said that she would do anything in her power to prevent that. All of this was occurring in the context of recurrent hospitalizations for severe exacerbations of his illness, and the patient's wife and mother were pretty much present 24 hours a day at his bedside whenever he was in the hospital, which made having private conversations about this topic very difficult. So my question at the time, and my question again for us today, is how can palliative care professionals, together with an interdisciplinary team, support patients and partners such as this couple, and minimize distress regarding reproductive planning at end of life? To provide some background framework for the rest of my talk, I want to start off by establishing how important the topic of fertility is to seriously ill patients. Patients often worry about disease and treatment effects on fertility, and many feel conflicted about whether to pursue fertility preservation. Greater reproductive concerns in cancer patients have been associated with lower quality of life scores, more cancer-specific distress, and higher rates of depression. This is a quote from a focus group study of female cancer survivors reflecting back on fertility in the context of their disease and treatment. And this woman said, "I feel like I've known from a young age that I love kids. The thought of not being able to go through that process of being pregnant was very, very scary for me." This is a diagram from a different study interviewing pediatric cancer survivors and their parents. And you can see here that the major theme that came up for both groups was regret that the issue of potentially compromised fertility had not been adequately addressed at the time of diagnosis. I also think it's interesting to take a look all the way down at the bottom of both columns and see how small the theme of embarrassment on the side of the parents and fear of talking to parents about sex on the side of the patients was compared to the theme of regret. Patients and families really want counseling on this topic, and they're looking to their providers to initiate that conversation. This is a quote from a pediatric cancer survivor. "My parents, conservative parents, don't really know how to bring up that topic, but I wish the doctor would have brought it up with me." And this is a parent saying, "I did nothing, and then I lived with torment for years." Interviews with providers suggest that they underrate how important families and patients feel it is to bring up fertility promptly after diagnosis. This is a provider. "It's too much all at once. Diagnosis, treatment, future, and parents often do not want to hear it anyway, so I don't add to their stress or mine," as opposed to a parent's perspective. "The evening before the start of the chemotherapy, the child was told about possible infertility and semen preservation. Later on, we told them that the timing was really bad. We felt it was mentioned too late. They should have mentioned it during the first conversation." Fortunately for us providers, we do have guidance from professional organizations about when and how to provide fertility counseling. The American Society for Clinical Oncology recommends fertility counseling at diagnosis. They also state that there are benefits for providing ongoing fertility counseling throughout the patient's cancer journey. And they say that when patients or families are expressing distress about this topic, that they should be referred to psychosocial providers. The American College of Obstetricians and Gynecologists agrees with the ASCO recommendations and also specifically strongly recommends that patients who are producing genetic material in preparation for cancer treatment, so sperm, eggs, or embryos, document their wishes in writing about what they would want to happen to that material were they to not survive their cancer. There's fortunately some evidence that fertility counseling is successful at alleviating distress for patients and families. multiple studies have shown that patients who received fertility counseling report less regret and depression and better coping and physical and psychological quality of life. Unfortunately, it seems like our current efforts at counseling are not adequate or not penetrating as much as we wish they were. A survey of over 2,700 childhood cancer survivors showed that 50% of them did not remember being counseled at all. And the mean age of patients in that study was 25, so it's not just that they were too far out to remember. In another survey, up to 62% of female cancer survivors reported having unmet information needs about their fertility. It's appropriate to ask why patients are not getting enough information about fertility. And there's some evidence to suggest that part of the problem, although I will say I don't think all of it, is that providers are simply not providing enough counseling. This is some data from a 2011 survey of pediatric oncologists, and 46% of them, only 46% reported following the ASCO recommendations to provide counseling to males post-puberty over half the time, and only 12% reported doing so for female patients. And I think it's also interesting to ask ourselves why there's such a gender difference, although I don't know the answer. One of the other conclusions that I've come to through preparing for this presentation is that a large part of the issue is that patients and families are not receiving ongoing counseling about fertility and reproduction after their initial diagnosis. I also think that while patients may be receiving counseling on fertility preservation options, they're not being offered a lot of psychosocial or spiritual support in processing concerns about fertility. To illustrate this, I want to pause for a moment and tell you about one of our patients here at Partners who Sarah Byrne-Martelli helped to take care of. She's one of our chaplains here at MGH. Sarah was called to see a young woman in her 30s who was dying of a metastatic gynecological cancer. Her husband was there as well. The woman told Sarah that she needed her help processing something that she hadn't had a chance to process at all since her diagnosis at Dana-Farber. At this point, her husband interjected, "We froze 10 kids," which, as you can imagine, was rather unusual phrasing and a little bit shocking to Sarah's ears. The patient and her husband went on to explain that they had frozen 10 embryos, hoping that she would survive her cancer and they would go on to have children. Now, however, that it was clear that she was not going to survive her cancer, they had to decide what to do about the embryos, and they hadn't talked about it at all. Sarah helped to facilitate a conversation between them, and the husband, who had a Christian background and believed in heaven, said that he would be willing to hire a surrogate to bear their children so that the patient could look down from heaven and see her children and grandchildren and come to know them that way. The patient, however, whose background was Jewish, didn't seem to share the same perspective, and after talking it through, decided that she did not want her husband to use their embryos to have children. He agreed to follow her wishes, and at the end of the conversation, the patient turned to Sarah and told her how relieved she felt, that a weight had been lifted off of her shoulders. She passed away 2 days later. Sarah shared with me that this was a hard case for her, and that she had felt fairly unprepared to help guide this couple through this process, since this was a topic that she wasn't very familiar with. Reflecting back on this story, I think we'd all agree that Sarah provided a great service to this couple by helping to facilitate this difficult conversation and helping to provide them with some resolution before her death. But I also think it illustrates how our medical system is failing to uncover patients' ongoing worries and distress about fertility, and how we often wait too long to provide support. This leads me to the question of what the major barriers are that complicate reproductive planning for patients. And I think there are barriers on both the patient's and family's side as well as on the providers. To start first with barriers on the patient's side, The first thing is that patients are often being asked to make decisions about fertility preservation at the same time that they're receiving their initial diagnosis and formulating an initial treatment plan. In this context, it can be easy for patients and families to initially overlook fertility concerns when they're focused on simply trying to stay alive. Secondly, this topic can provoke immense anxiety for patients and families, as it did for the patient that I spoke about at the beginning of my talk. Patients and partners may not agree and may have trouble coming to be on the same page together. That was actually initially also the case for the patient I spoke about, which I'll tell you about more later. This is an immensely personal topic for many people, and patients may not feel as comfortable as my patient's wife did bringing it up with their providers. There are also significant cultural and religious factors that can make this much more complex. Imagine, for example, a young adolescent boy in a very religious family who's being asked to masturbate as part of sperm banking prior to cancer treatment. This isn't acceptable in many cultures or religions, so it raises a question of how do we go about approaching that and how do families think about that. Imagine also a religious couple that's created embryos and has to now decide what to do with them. Are they going to use them, or possibly might they end up being destroyed? And is that something that violates some people's feelings about preservation of life? Lastly, patients and families have to make decisions about fertility preservation quickly to minimize delays in treatment, which, as you can imagine, can make such decisions feel forced or rushed. This can be especially difficult for younger patients who may not have yet considered their reproductive goals. But even for older patients, the time pressure can also sometimes force them to make decisions that they might not otherwise make. For example, Dr. Mary Sabatini, who's the medical director for the Clinic for Reproductive Health and Cancer here at MGH, told me about a patient who she saw in her clinic prior to initiation of cancer treatment for fertility preservation. The woman was in her late 30s, was well educated, was married, and throughout the visit, she was extremely tearful and hesitant to discuss her fertility preservation options with Dr. Sabatini. Dr. Sabatini found this a little bit surprising, given that she figured that an older woman with good health literacy who was married would have already considered what her reproductive goals were. And it wasn't until a future visit that the patient confessed to her that she and her husband had always hated children and had never wanted any, but that she was so upset that something was being taken away from her without her permission that she decided to go through fertility preservation just to maintain a sense of control and independence. So it's important that we not make assumptions and that we remember that conversations about fertility conversations are uniquely challenging for each individual. Barriers to reproductive planning for providers have a little bit more evidence behind them because there have been surveys looking at what they are. Some things that come up in these surveys are lack of knowledge about how to counsel patients about fertility options and not really knowing how to start the conversation, worrying that the topic is inappropriate, uncertainty about roles of who should counsel and who should counsel on what part of fertility preservation, complexity of cultural and religious factors, as I've talked about. And some providers have also talked about ethical concerns about helping to bring a child into the world who has a parent who may imminently die after the child's birth or even before the child is born. Not to keep hammering too much on barriers here, but there are also logistical barriers for reproductive planning. The first is that fertility preservation can delay treatment. Fortunately, the timing of the delay has shortened significantly with more advanced technologies. So most fertility preservation options can be completed within a couple days or at most 2 to 3 weeks. Patients who are severely ill, hospitalized, or in that dying process may not have the mental status, the privacy, or the time to discuss reproductive plans with people who are important to them. And they also may not be able to go through the medical steps necessary for fertility preservation. Hospitals, particularly hospitals that are less resourced than we are or in more rural areas, may also have trouble facilitating fertility preservation for patients who are admitted. There's also paperwork involved in a lot of this process, and particularly in transferring custody of genetic material that's produced. And this can really add significant bureaucratic stress to an end-of-life setting. It's important to think about how cost plays into this. Many fertility preservation options are not covered by insurance, and even storage can be very expensive. Just to give you a little bit of a sense of that, Dr. Sabatini told me that at MGH, storing genetic material costs about $850 a year. And at the New England Cryogenic Center, which many of our patients use, it costs about $475 to store sperm for 1 year. And you can imagine that for certain families, that's a prohibitive cost, especially on top of other medical bills. And also certainly if it goes on for years, can add up. I want to talk a little bit about what different options for fertility preservation are, not because I expect any of you to know all the details and be able to provide these options to patients, but because I think it's something that our patients are being presented with and may contribute to some of their decision-making and stress. For females, it tends to be a little bit more logistically complicated, but also they tend to have a few more options overall. So the first is oocyte cryopreservation or freezing eggs. The second is embryo cryopreservation or freezing embryos, which sometimes can be more successful down the line than freezing eggs. A third is something called ovarian transposition or oophoropexy, where for patients who are expected to receive radiation to pelvic organs, you can remove the ovaries and fallopian tubes and reimplant them in the abdominal wall to protect them from radiation. There's also ovarian tissue cryopreservation or freezing and then retransplantation, which is a newer technique and is not for females considered experimental any longer. So that's freezing part of or the whole ovary and then reimplanting it either in the pelvis or sometimes in the skin under the arm and then extracting eggs from it. It's actually been successful. There's also ovarian suppression with gonadotropin-releasing hormone receptor agonists such as leuprolide. This tends to be used most often in breast cancer patients, but there's conflicting evidence about how effective this is, and it doesn't tend to be one of the more recommended methods. And then, of course, there's gonadal shielding with lead if people are going to receive radiation near pelvic organs and to try to protect the pelvic organs themselves. For men, most of the techniques revolve around somehow getting the sperm out. So you can do that through aspiration, through banking in a typical way, or through extraction where you actually take part of the testicular tissue and extract sperm from it. Testicular tissue cryopreservation or freezing testicular tissue is actually still experimental, and they're still looking into that. And just to say that for children who have not yet reached puberty, ovarian tissue cryopreservation or testicular tissue cryopreservation may be the only options available to help. The question of what happens to genetic material after death is extremely legally and ethically complicated, and becomes even more complicated if no genetic material was stored before the person's death. In this case, there's something called posthumous gamete retrieval. This is where things start to get a little complicated, so stick with me. So posthumous gamete retrieval is extraction of sperm or eggs from a deceased person's body. And as I said, there's not a lot of consistent policies or laws governing how this can be done. Fortunately, there's a really thoughtful ethics statement from the American Society for Reproductive Medicine that goes through this, that if people are interested in this topic, I highly recommend that you read because it's fascinating. And I'm going to talk a little bit about this recommendation and what they say, but the bottom line is that the right to reproductive autonomy should be respected even after death. So what does that mean? So custody of genetic material does not automatically transfer to anyone in particular. So if the person of origin dies, the wife or the husband left behind does not necessarily get custody of that material. In order to use genetic material to reproduce after someone has died, you need evidence of that person's wishes. And you need evidence of what they wanted in terms of childbearing, but also in terms of whether they would have wanted to have children if they were not going to be there to parent that child, which, as you can imagine, is not a conversation that most people have routinely. The patient's spouse or life partner is considered to have the greatest claim to reproductive material. And that's because they're considered to have a shared reproductive interest. So for example, a given patient's parent or child or friend never shared with that patient an idea that they might have children together. And so they are not considered to have a shared reproductive interest with that patient. ASRM also recommends that time for grieving and counseling be given so that no one is making rash decisions about whether to have children in the context of acute grief. As I mentioned, policies and laws governing this are very inconsistent. So ASRM recommends that centers should develop written policies with respect to posthumous gamete retrieval. And I think it's interesting to know that laws vary on whether resulting children are legally recognized as offspring of a deceased person, which can have significant legal ramifications for families. I want to tell you a little bit about a really interesting case from Brigham and Women's Hospital that was written up last year as an ethics brief. And this case actually prompted them to develop a policy about posthumous sperm retrieval. So there was an elderly man dying in the ICU after suffering from a pretty severe stroke. And his daughter approached the medical team and requested that his sperm be retrieved after his death. And when the medical team asked her why she wanted this, she explained that in the country where they were from, they had a family estate that could only be inherited by a male heir, which the patient did not have. However, it was unclear what the patient's wishes were, and it was also unclear who would use the sperm and how that would be used. Brigham at the time did not have a policy about posthumous sperm retrieval, and they were not alone. So in 2017, there was a survey of 75 academic medical centers, and 41 responded. And of that 41 that responded, 11 had policies about posthumous sperm retrieval. 1 had banned it, 4 required a prior written consent from the patient himself, 6 allowed for a partner to provide consent, and 5 required a bereavement period before the reproductive material could be used to produce a child. Just to say that MGH does not currently have a policy, but apparently it's something that's been talked about. Back at Brigham, ethics and risk management were consulted in response to this case, and they developed the following policy. Evidence of the dying or deceased man's written consent for perimortem sperm retrieval must be presented before such a request can be fulfilled. The dying or deceased man's spouse or life partner must be the person to both request and use the sperm. And if a request for posthumous sperm retrieval is made, a formal ethics consultation must be obtained. So you can see actually pretty consistent with what the ASRM brief recommends. To tell you a little bit and to show you how murky this all can be, I want to tell you about another case that happened this year in New York that had a very different outcome. So this is Peter Zhu. He was a 21-year-old West Point cadet, and he went skiing in February and suffered from a severe skiing accident and was declared brain dead 4 days later. And his family petitioned for a court order to have the hospital extract and store his sperm. And their evidence that they provided was this. Peter told us he wanted to have 5 children and that his dream was to live on a ranch with his family and raise horses. So I think if you kind of match this back up to what I've been talking about as the guidelines, the parents are the people requesting for the sperm to be stored, so not a partner. There's no written evidence of what he would want. There's some verbal evidence of what he would want, certainly with respect to whether he wanted to have children, but not a lot of evidence about what he would have wanted if he weren't going to be there to parent his children, because what 21-year-old is really thinking about that? The judge who handled this case in New York did order the hospital to extract and store his sperm, but did not make any specifications about whether that sperm could be used and how and when. So that actually remains up in the air still. You may be thinking, oh boy, I'm overwhelmed. What is my role in all of this? And you're not alone. So this is a nice blank slide for you to take a breath and prepare yourself. I'm going to talk a little bit about what I think our role is here. And my next slide, I will warn you, looks complicated at first, but will provide you with much clarity. So I propose that there are 4 realms to counseling on fertility and fertility preservation. I propose that we start in the upper right-hand corner of this wheel. So for counseling on the effect of disease and treatment on fertility, that's something that I think can be spearheaded by the patient's primary care providers at the beginning of their diagnosis. So their oncologist, surgeon, and radiation oncologist who are handling their case and developing a treatment plan. Counseling on what their fertility preservation options are would probably be provided as a pair conjunction between the oncologist and fertility specialists. Counseling on ethical or legal considerations might not apply to every patient, but certainly if that comes up, very helpful to loop in legal experts, ethics teams, and fertility centers do have some experience with this as well. The 4th realm is the one that I'm the most interested in and the one that's really the focus of my talk today. And this is where I think our field has the most opportunity for involvement and also the most opportunity for growth. So counseling for existential, family, and spiritual distress. And I think palliative care, social work, chaplaincy, psychology, and psychiatry all have potential roles to help with this. If you're thinking, I'd love to help, but how in the world would I even start a conversation with a patient about this? This is a little bit of suggested language, which you're welcome to adapt or change. Many patients worry about how their disease or treatment might affect their opportunity to have children. Has this been on your mind? From there, I think we can go on to use the communication skills that we use with patients every day. Respond to emotions that come up. Explore hopes and worries about fertility. For patients who are having trouble existing within a reality where they might not be there to parent their children, explore hypothetical situations with them. And for patients who are experiencing conflict with other members of their family, you can try to name the dilemma. For example, for my patient and his wife, it sounds like this is a topic that's really important for your wife to have some resolution on, but it's very difficult for you to consider it. Where do you think we should go from here? Circling back around to the patient who I spoke about at the beginning of my talk, I want to tell you what happened. So his wife, as I mentioned, articulated her distress pretty clearly, both to the palliative care team and the oncology team. And we validated her concerns, but really were not quite certain how to guide her beyond that. She approached the patient with her worries and concerns and told him that she wanted to be able to have custody of his sperm to possibly use after his death to have a child, and he initially refused permission for that. And I don't know exactly why I wasn't there for that conversation. I suspect from knowing him that it had a lot to do with him not even being able to tolerate that idea or that conversation, and just saying, of course I'll be here to be a parent with you, why wouldn't I be? She approached the oncology social worker who helped her strategize about how to reapproach the patient also helped. He was admitted at the time to remove his mother from the room and to provide a private and uninterrupted space and time for them to have further conversations. And when they did that a second time, and the patient's wife made clear to him how important this was to her, he did agree to transfer custody of his sperm. As far as I know, his mother was not aware of that. The social worker, again, helped them to fill out the necessary paperwork and to fax it, and the wife did obtain custody of his sperm. However, this all happened only 2 days before he died. So as you can imagine, this added another dimension of distress to their end-of-life experience. I don't know exactly where her thinking is now about what she wants to do with his sperm. I do know that she adopted a black lab puppy that she named after the patient's favorite drink, and that she's really enjoying being a mother to the puppy. Thinking, as I reflect back on this case in the context of what I presented to you today, and I think about how I would approach a similar couple now, I think this is a little bit of a framework of what it could look like if I were to do it again. I think if there was a chance and if the patient gave us an opening, we could have screened the patient and wife for distress on this topic, and then hopefully made referrals to the most appropriate people. So depending on kind of what came up in that conversation, social work, chaplain, a psychologist or psychiatrist, or back to a fertility center. The patient's wife, for example, did have some specific questions about whether their money could be refunded if the patient had died in terms of the storage and process of retrieval. Hopefully those wonderful interdisciplinary colleagues could help the patient, counsel the patient and wife, and help them to come to a decision before the very end of life period, and then could have helped them enact a plan to make that a reality. I think another part of this process that I haven't talked a lot about yet so far in my talk is the bereavement process. And I think that this is something that extends beyond the patient's death and certainly involves a lot of ongoing grief and loss for the patient's family, not just of the person who died, but of grandchildren or great-grandchildren that they had expected to have. And it's a really major disruptor of the life cycle. So I think it's important too that people providing bereavement counseling for the families of these patients, young patients of reproductive age, are aware that this might be something that had caused distress and might want to involve that in the bereavement counseling process. I want to read to you a little bit from When Breath Becomes Air, which is a book that was written by Dr. Paul Kalanithi. Paul Kalanithi was a neurosurgeon who unfortunately was diagnosed with metastatic lung cancer and died at age 37. And he writes very beautifully in this book about his cancer journey, and also writes about a discussion that he and his wife Lucy had about whether or not to have children. And I think that this provides a pretty intimate window into what this conversation and the thought process is for a particular couple. Both of us yearning to be parents, we each thought of the other. Lucy hoped I had years left, but understanding my prognosis, she felt that the choice whether to spend my remaining time as a father should be mine. I knew a child would bring joy to the whole family, and I couldn't bear to picture Lucy husbandless and childless after I died. But I was adamant that the decision ultimately be hers. She would likely have to raise the child on her own and to care for both of us as my illness progressed. Will having a newborn distract from the time we have together? She asked. Don't you think saying goodbye to your child will make your death more painful? Wouldn't it be great if it did? I said. Lucy and I both felt that life wasn't about avoiding suffering. After so many years of living with death, I'd come to understand that the easiest death wasn't necessarily the best. We talked it over. Our families gave their blessing. We decided to have a child. We would carry on living instead of dying. So in conclusion, I don't want you to walk away from this talk thinking, oh man, in addition to everything else I'm already doing, I now have to counsel patients on their fertility at their diagnosis and all their fertility preservation options and carry them from point A to point Z through this. But I think that I do want you to understand that reproductive concerns are a huge source of ongoing distress for young cancer patients and other patients facing other life-limiting illnesses, and that this process compounds grief for the patient as well as for their families. And I think our system right now is under-recognizing how much distress this causes, and we're not currently providing enough counseling to address it. And I think that we're really uniquely positioned as a field to be able to screen for this distress using our advanced communication skills and use our experience working with large interdisciplinary teams to really loop in our interdisciplinary colleagues to provide support to patients and families going through such a difficult process. I have more people to thank than I could go through one at a time, but this was certainly a collaborative effort, and I really appreciate everyone's support and help and encouragement. And these are some resources. And I really want to thank everyone so much for your attention. I know this is a little bit of a heavy way to start a Wednesday morning, but you've been really wonderful, and I'd be very happy to take any questions or comments.
That was fantastic, Joanna. Thank you for opening our eyes to what our patients often experience in isolation. I've been happy to hear you gain expertise on this talk and talk about it in multiple different venues. And one of the last places you talked about it, there was an oncologist who juxtaposed this case to a young female patient who was thinking of hiring a surrogate, even though she would likely die before the child was born. And I'm just reflecting that the audience had a very different reaction to that than they did to this particular case. And so I wonder if it brings up issues of our own unconscious biases about what it means to be a mother versus what it means to be a father, and if you have reflections on that.
Yeah, I think that's a really good point, and I think that ties a little bit into that slide that I showed about the pediatric oncologists and the difference in counseling that they provided to male patients as opposed to female patients. And I think also just it speaks to how logistically it's a little bit more complicated often if the woman is the one who's dying to do the preservation. I don't know that that explains it all. I think you're right, there's something psychosocially that feels heavier about having a surrogate or someone else bearing a child for a surviving male partner. And I also welcome if other people have thoughts about that. I think I haven't read a lot about that, but I think that it is a very different process.
Let's open it up to the room.
Hi, Joanna. Thank you so much. I'm so glad you brought this topic up because I think it's very, very important and a wonderful presentation. Also, I want to just emphasize what you pointed out about having these conversations earlier because I've had just a handful of patients over the years, male patients, inpatient, who, the oncologists say, we're going to start chemo tomorrow, and then they bring up the conversation, do you want to, bank your sperm? And then the kind of, then they start thinking, oh, I guess I will, but then the pressure that mounts within them to have to, you have to do it within a certain amount of time. There's all this pressure. But the one part of it that I've always found out, unfortunately, nobody's been successful that I've worked with and being able to produce because they've been in the hospital. A lot of times they're just physically not comfortable or able to. But at the end, they've at least feel that they were able to at least try. And so there was some comfort in that for them. But we just want to emphasize again the notion of having these conversations earlier so we're not left with these situations, at the very, very end. So thank you very much. Great talk.
Hi, I'm Sarah, the chaplain, and I thank you for this. This is incredibly interesting and brings up so many questions, as you noted. Oh boy, what do I do now? I just wanted to add one thing about that story, which is that I had gone to see this patient. She was a GIP hospice patient, so I had just gone to do the spiritual assessment as one does. So I actually really just stumbled upon this question. It wasn't something I knew about, and as far as I could tell, where I sort of delicately spoke to the other members of the team after, no one else on the team had any sense this was an issue. It was sort of like, oh, and the husband was, his grief was sort of frantic and he couldn't stop moving and he was kind of all over the place. And she was like, oh, while the chaplain's here, I guess I'll bring up this issue that's been weighing so heavily on her. But it was this sort of surprise type of conversation, but what a profound conversation. And for her, it was really about, really not to be dramatic, but really the death of her self as a mother, a death of her image of herself as a mother. And again, brings up so many issues about life and our frozen embryos. You know, we froze 10 kids. And how does that play in? So I guess, again, just to emphasize just to even open up that conversation and the value of the interdisciplinary team. Thank you so much.
I love this. This is awesome. And just to think, from that really intense patient encounter we had in clinic, all of this was born, no pun intended. The question I have is, I feel like I have seen oncologists struggle, although I agree with your schema that it starts in the upper right-hand corner. What are your thoughts about, I find that for patients for whom the prognosis is very short, oncologists really struggle in this space for a variety of reasons. One, to bring it up because it's often that the patient's prognostic awareness is low and they can't actually say, you could choose to make these decisions about your reproductive health, but you should know you are unlikely to be able to parent that child. This feels really weighty. And then I've also had oncologists say, it doesn't make sense. Why am I offering something that actually can't ever be actualized, which feels very different than somebody who has got a very good prognosis from their illness and is likely going to be able to actualize whatever those goals are. So I'm just wondering what your thoughts are about that and how do we help in that space? Because sometimes we're involved and the horse is out of the barn. Like they've already gotten all of their treatment and they haven't, it's interesting because in those spaces, I found myself sometimes advocating for the patient to the oncologist saying, hey, they're not there yet. And this young man banking sperm, I think this is where we need to be right now because this is where the patient needs to be. And that can be really hard for the oncology team to hold sometimes because it feels so clear that the patient's prognosis is so short.
Yeah.
What do you think about all that?
Yeah, I think it's so rich and complex and complicated. And I think you're right that this is something that oncologists and all of us struggle with. And I think that's partially why I propose that we can have a bigger role in this because we're used to holding that complexity and those conflicting hopes of I want to have a future, I want to have a child, and also I'm dying and my future is being taken away from me together in a space. I think that one thing when I was talking to Dr. Mary Sabatini that she said she asks sometimes is, what were your plans? What were your thoughts about having children before your diagnosis? What were your plans for having children before your diagnosis? And that's something important to bring up with people to just get it out there, and then kind of going from there to say, okay, hearing what your goals were previously, I think these are the different possibilities that you might encounter. And I think it's many of these patients are living in a gray space where they're being told by an oncologist, probably your prognosis is not good. There is a small chance that we can stretch this out a number of years. If we were to be able to do that, do you want some of those years to include being a parent? I think there's another subset of patients where they're saying, you have this patient, you have a very short prognosis. He only lived 3-4 months after his diagnosis. You have a very short window. And he would never have been able to tolerate that conversation out of the gate. I think his wife may have been to tolerate some of that. And so I think, sometimes if you're dealing with a patient like that, using these communication skills and these questions on other members of the family, and then kind of thinking together about how can we bring this up with the patient in a way that feels safe, and a way that provides a safety net, is sometimes maybe the way to go, rather than just kind of coming right out at the patient with it. Does that answer sort of a little bit?
I think that this is an important space for us, especially in early integrated palliative care, when we're getting called in to see these patients, to actually do the same work with the oncologist, right? So I think this is us being able to do that with everyone, because I think there's a fair amount of moral distress on the part of the oncology team as well, that there may not always be a space for them to process.
Yes. providing palliative care to our colleagues.
I just want to say thanks for bringing more awareness, because I think I am a hospice nurse, but also worked in women's health and delivery for a long time. And watching my patients with their frustration at not even being able to sort of verbalize those concerns, their loss as a parent, loss of the choice, sometimes even being able to explore that just brings some sort of peace. I found that those conversations are very difficult. I work as a referral nurse, bring people on hospice, from GIP or whatever, and just trying to touch all the bases. And part of it is also just having to assess what they know and what they've taken from these conversations. Some things they may have been told or talked about, but after that initial diagnosis conversation, nothing's getting past the door. So, even being able to, as a team, bringing those conversations to the front again to explore them, just to make sure that they're attended to, so that they can help the family and the people who are passing or who are dying have a good death. I think that makes a big,
yeah.
I want to open it up to any questions at our remote sites.
Us?
We can hear you.
Oh, hey. So
Hi.
thank you for this topic. It's very timely. I have a 16-year-old and a 23-year-old, but both of them do not have life partners. I worry about starting a conversation when there's not a very clear recommendation on what to do with the genetic material if they've died.
Yeah, that's a really good point. I think that a lot of young cancer patients are in that position. And certainly when you think about the pediatric population where a lot of this is being dealt with, that's most often the case. And I think that what I'd say about that is a lot of what I've learned from reading about this is that just because someone's not partnered doesn't mean that this isn't something they've thought about or important to them or weighing on them or part of what they're grieving. And I think that in the vast majority of people who are in that position, most of them are not going to have an outcome from that conversation that's tangible. Most of them are not going to say, okay, great, I'd like to have my eggs harvested and they'll be stored and then I'll transfer the custody to my parents and then they'll hire a surrogate. I think that does happen, and that's possible to happen, which is part of why sometimes in a very small group of people, it's also valuable to have that conversation to get that outcome. But I think most of the time when you're bringing up this conversation, it's more to say, hey, is this something that you're keeping inside? Is this a worry, a stress that you're keeping inside, that you're grieving, that you're never going to become a mother, that you'd like to just talk about? You'd like to just put on the table, and you'd like someone to listen to you, and you'd like me to help, get a psychologist in here to help you process not just the loss of your life, but the loss of the role of parenthood that you're going to experience. And I think there's a lot of value in that as well.
Excellent. I think we'll stop there for the sake of time. Thank you, Dr. Sharpless.